morning. Welcome to ATCM. Today I will be presenting a case on neutropenic sepsis. Can I start, sir?
Yes.
A 66-year-old female was brought into ER in a trolley. On initial 10-second assessment, patient was conscious, oriented and obeying commands, but she was tachypneic, sir. Primary survey, her airway is patent, there is no secretions and C-spine appears normal. There is no gurgling or stridor. Breathing, her respiratory rate was 26 per minute. She was tachypneic. Chest exertions
What are
were
the reasons
normal.
for tachypnea in emergency room?
Maybe because of pain,
Okay.
anxiety, then maybe because of respiratory distress.
Respiratory distress due to various causes.
Rib fractures, pain related to
Then.
that.
But
Abdomen
most common cause you are not telling.
Hypoxia.
Hypoxia she has already told. Respiratory distress. Acidosis. Acidosis is one of the most important cause, not most common. Most important cause you should never miss. Okay. There on patients, if you are not ABG is not available for at that moment, rapid breathing is one of the earliest sign of acidosis for the correction. Okay. How do it correct acidosis? Rapid breathing.
it is metabolic as a part of compensation. Body belly washing out carbon dioxide. Air entry was bilaterally equal, sir. Saturation was 99% in room air itself. Circulation, her blood pressure was 150/70 with a MAP of 93. All peripheral pulses were felt equal and bilaterally, but her heart rate was 112 per minute, sir. Her disability GCS was E4V5M6 and pupil was 2.5 millimeter reactive. GRBS was 102. Her temperature was 100 degree Fahrenheit and hypothermia was prevented by blanket. Adjuncts to primary survey, she was kept in a proper position and arterial blood gas was asked, sir, at this point of time, which was showing a pH of 7.3, PCO2 of 28, bicarb of 17 and lactate of 17.7, sir. So maybe it's a lactic acidosis, metabolic acidosis, lactic, probably lactic acidosis.
You have a very good BP.
Yes, sir.
You are getting lactic acidosis. What do you think the reason?
Maybe because of the tissue hypoxia.
Due to what?
Two types are there, sir. Maybe because of the reduced circulation or
Here BP is good, MAP is good. Still you are telling it is reduced circulation.
Drug-induced.
No, if you are not getting a circulatory collapse, you have to think about other reasons for lactic acidosis, especially patient may be on some drugs that should be ruled out. Any toxins or toxicity due to sepsis. Okay. One part is hypoperfusion and lactic acidosis. Drug-induced mitochondrial change is another one. So both should be suspected. When there is a lactic acidosis, all you can think about seizures also. Somebody is having seizure just before coming here. High lactate indicates seizure-induced lactate. Okay.
PCO2 was low, right?
Yes, sir. Maybe compensations as a part of compensation.
So here the rapid breathing is due to acidosis. Okay. So I told acidosis is one of the most important cause, not most common, but it is not important cause you should never miss.
IV cannula was inserted and blood samples.
What's the creatinine and ABG?
Creat was 0.7, sir. And paracetamol. Sugars was 98. Then sample history, sir. Patient is a diabetic and hypertensive on irregular medications. Patient is a known case of rheumatoid arthritis diagnosed 1 year back and she is on hydroxychloroquine, TID, hydrocortisone, leflunomide and sulfasalazine.
So if you see these drugs, hydroxychloroquine sulfate, what are the adverse effects of hydroxychloroquine sulfate?
It can cause oral ulcers.
It can cause blackening of skin. It can cause blackening of the retina, retinal pigmentation, visual loss. All these things can happen. Other drugs?
Hydrocortisone.
That is steroid. And then
Sulfasalazine and
sulfasalazine. Sulfur drug is sulfasalazine is a sulfur type of drugs. Okay. Then other one?
Leflunomide.
In that, which drug can produce hemolysis?
Liflonam.
Sulfur drugs, all sulfur drugs can produce. Leflunomide normally have allergic rashes and Stevens-Johnson-like syndrome, but any side effects are possible, like liver injury, kidney injury, everything is possible.
4 months back she
hydrocortisone, long-term hydrocortisone.
she
What's
that
the
time
initial, steroid given in RA?
prednisolone can
Prednisolone.
be given.
Hydrocortisone is not routinely given. It is given for mainly steroid replacement therapy.
4 months back she had a history of pain and swelling all over the joints and fever, and she was admitted in outside hospital. That time she was diagnosed to have pancytopenia, for which HB was very low and blood transfusions were given, and they evaluated for pancytopenia and bone marrow was done, which was inconclusive. And then further management details are not available. And
what are the reasons for anemia, thrombocytopenia, neutropenia in rheumatoid arthritis?
Maybe drug induced methotrexate.
Most common is one is drug induced, like methotrexate. Okay,
then some associated symptom, associated autoimmune conditions.
Other autoimmune hemolytic syndromes or destruction of the platelet, neutrophils, all these things. Then
Felty syndrome.
Felty syndrome is a syndrome associated with rheumatoid arthritis, where you have rheumatoid arthritis, neutropenia with splenomegaly, splenic destruction of the cells.
Then associated with HLH mass, like that.
Okay, that is also possible. But most important thing is anemia of chronic illness.
Disease.
Any chronic illness can produce bone marrow suppression. The patient can have all type of failures, like neutropenia will be there, anemia will be there, thrombocytopenia is there. But anemia is the most prominent symptom in that. Okay.
Before marrow, is there any other simpler test which could have given us some insights about anemia and
Peripheral blood smear, sir. That report is not available, sir. There, but they have a bone marrow report which is inconclusive.
and that could be because of sampling issues also, no? That may not be.
Yes, sir. Yes, sir. Now this patient presented with a history of fever, chills, rigor and body pain to outside hospital. There also when they checked, her HB was 10.1 with a
Any rashes are there on the body?
all ecchymotic lesions during presentation to our hospital. Ecchymotic lesions.
If there is rashes associated with fever in rheumatoid arthritis, what do you think?
Stills.
Adult chills disease. Rheumatoid arthritis will be there, chills will be there. Associated with fever, they have rashes. Once the fever subsides, the rashes will subside. Okay.
Outside her HB was 10.1, a total count of 1400, and absolute neutrophil count of 700 with a platelet of 65,000, sir. And there she had a conjugated hyperbilirubinemia, hypoalbuminemia and elevated OTPTs with high ferritin and LDH. Outside ferritin was 1600,
Okay.
and USG suggestive of
What happens in adult chills disease ferritin?
elevated.
It will be highly elevated, 10,000, 20,000 like that. Okay. 1,000 just indicates some acute inflammation. It's an inflammatory marker. Okay.
LDH, how elevated was it?
LDH outside it's written as elevated, but in our hospital our LDH was 3,400.
What do you think? What are the reasons for high LDH?
Maybe because of the inflammatory condition itself, LDH can be elevated. Hemolysis.
Most important is hemolysis. Okay. In rheumatoid arthritis itself, hemolysis can occur because of immune mediated hemolysis, and splenomegaly in Felty syndrome can also produce peripheral destruction and hemolysis. Okay.
What is the differential cause?
Differential counts, our differential counts, in our hospital total count was 840 with a neutrophils of 58%, so absolute neutrophil counts coming around 487.
Okay, it's very low.
4 sites 7.
Less than 500.
And there in the outside hospital, her screening pre-op serology HbSAg became positive, sir.
Okay. Pre-op serology is not a good investigation for making a diagnosis. So it only tells that there is a possibility. Ideally, we have to send ELISA only. Okay.
Then on examination, sir, she was having pallor, icterus was there, and edema was also there, and multiple ecchymotic lesions or bilateral pitting pedal edema, sir, and ecchymotic lesions over the skin, sir.
What are the reasons for edema in rheumatoid arthritis? Can you tell me? Reasons for edema. She has told anemia is there, but that may be the cause here, but other causes. If you go into the deeper aspect of rheumatoid arthritis, what will happen to the kidney?
Acute kidney injuries.
Amyloidosis. Amyloidosis is one condition which can present with peripheral edema, hypoalbuminemia, renal protein loss, all seen in rheumatoid arthritis. It's a secondary amyloidosis. We have to think that, but here it may be due to anemia. Okay.
Where will you look for edema? Where all? How?
Sir, sacral region and bilateral medial malleolus. Then mostly these two regions.
Okay.
Then system examination, sir, respiratory system examination, she was tachypneic. Other than that, respiratory system trachea appears central, sir. Bilateral air entry was equal, no added sounds. Per abdomen examination, per abdomen was soft, non-tender. Tip of the spleen was palpable, sir. No hepatomegaly present. Central nervous system.
When you are examining the spleen, you have to tell completely what are the findings. In emergency room, you have to always look for the ultrasound and confirm, because clinical examination spleen may not pick up all the findings in a busy emergency room. When you examine a spleen, you have to look for the adjust borders, a notch, whether it is moving with the tenderness, whether it is moving with the respiration, bloatability, everything. Okay.
Cardiovascular system and central nervous system examination were within normal limits, sir.
Okay.
So we went into the blood investigation, sir. Her hemoglobin was 7.4 with a platelet count of 19,000.
Okay. What is MCV and MCH?
MCV and MCH was coming in the microcytic
towards lower side.
side.
So
sir.
you think that it's microcytic hypochromic
Hypochromic
anemia.
anemia.
It's seen in blood loss anemia, especially patients who are taking NSAIDs, chronic NSAID use, or anemia of chronic illness itself can produce microcytic anemia. Okay.
Then a total count was 840 with an absolute neutrophil count of 487, sir, which is coming as severe neutropenia, sir. Then bilirubin was 5, OTPT bilirubin 5 with a direct of 3.84. OTPTs were around 200, sir.
So the liver is slightly involved. Okay. Maybe he is on sulfasalazine. All these drugs can produce liver injury.
Then albumin was 1.8, sir.
Okay.
Urea was
What would that be?
chronic involvement, chronic
globulin. What is globulin level?
3, sir.
3. Okay. So maybe chronic liver disease you should rule out, because this patient may be on multiple drugs, like including methotrexate, which can produce liver fibrosis.
And hepatitis B is also.
Hepatitis B.
No, sir.
Hepatitis B is also there.
Yes, sir.
Okay.
Urea was 42.9, creat of 0.77. Electrolytes were within normal limits, sir. Ferritin was 6,562.
That is very high.
High, sir.
Okay.
Uric acid was 5.6. Fibrinogen was 629.
Fibrinogen also an acute phase reactant. There it is highly elevated.
Triglycerides was 424.
There is again, there is also an acute phase reaction.
Right.
Many types of acute inflammatory condition, including HLH, it can be elevated.
CRP was 241 with a procalcitonin of 3.87. LDH was 3,480.
Procalcitonin, what it is actually?
Inflammatory marker.
It's also again inflammatory marker. Highly elevated procalcitonin indicates a bacterial infection. Slightly elevated may be seen in many inflammations, including lung infections and all.
Ultrasound was showing splenomegaly spleen of 15 centimeter size.
Okay. What is a normal ultrasound wise normal spleen?
Up to 13 to 14.
13. Okay.
Her MACC score was calculated, sir. That was showing 16. A score less than 21 is a bad prognosis, sir. Less than 21. More than 21 is good, sir. Good prognosis. So this patient was admitted with this patient is having a neutropenic sepsis, sir.
What do you think that it is sepsis? This patient is having neutropenia.
Neutropenia, yes.
What is the evidence to tell it is sepsis?
History of fever is there.
History of fever is there. Neutropenia is there.
Neutropenia.
So we have to suspect.
Suspect.
When you have a history of fever in a neutropenic patient, you have to suspect. Okay, but sometimes the fever can be simply due to the inflammation of joint itself. But whatever it is, we have to suspect. Okay.
According to the definition, sir, if we are getting a temperature more than 100.9 degree Fahrenheit at one point of time, or a temperature of more than 100.4 in 2 different time, means it will be febrile neutropenia.
Okay.
So with the underlying rheumatoid arthritis and hepatitis B, sir.
Okay.
And probably because of a rheumatoid arthritis or associated rheumatoid arthritis with some like Felty syndrome or macrophage activation syndrome.
Okay.
So this patient was admitted in our ICU. In view of worsening of tachypnea, she was started on Bipap, sir. Then she was given her IVC was collapsible. So
This, just for clarity, why you started Bipap in this patient? You know that lungs are normal. There is no hypoxemia. There is only acidosis which is creating a tachypnea. What is the indications for Bipap in this patient?
Only to support the respiration, sir.
Why
Breathing to reduce the respiration.
He is not having any distress. He is compensating for his acidosis. In that condition, why we want to give a support? He is only trying to compensate. We are trying to reduce the rate.
Sometimes the patient is going to affect
Respiratory.
Is it really indicated? I don't know. Because patient is trying to compensate for a problem like it's acidosis. We cannot support with the Bipap for that condition. If there is an ARDS, hypoxemia, all these things we can support. But only supporting by Bipap is at this point. If the patient goes to distress, then it's okay.
She was going to distress. At that time, we started Bipap, sir.
Okay.
Then she was having lactic acidosis, sir, probably because of sepsis.
Acidosis under
pH of 7.3.
3.
Then she was admitted in the ICU. Her IVC was 0.7 centimeter, which was collapsible, sir.
Okay.
IV fluids were started, sir. Maintenance dose IV fluids was started, and subsequent ABG was taken after 2 hours to
Okay.
look
What is the HB in this patient?
HB was 7.4, sir.
Okay. Will it produce lactic acidosis in hypoxemia? Somebody is having somebody is having a severe anemia. So theoretically, it is also a circulatory failure. There is less number of RBCs. There is less amount of oxygen carried to the tissues. So there will be tissue hypoxemia in anemia. So that may add to the acidosis here, but that will not cause this much acidosis without any other problem. Okay. So here one of the aim will be correction of the anemia. That may correct partly the acidosis, lactic acidosis.
This patient platelet was also 19,000, sir, with bleeding manifestations in the skin. So she requires platelet transfusion also. So platelets were arranged and transfused, sir. Then along with after that blood products were given, sir. PRBC transfusion was given. Then she was started on antibiotics, broad spectrum antibiotics.
Why you start antibiotic in this patient?
She's already having neutropenia, sir. So she's very and with fever. So she's prone for infections, and she might be having an infection by now.
Okay.
So
what all antibiotics can be given in this patient?
According to the neutropenic sepsis, we can give according to the patient's presentation, sir. If the absolute neutrophil count is coming less than 1000, and if the patient is having other depending on the patient's presentations, we can start with a broad spectrum antibiotic with pseudomonal coverage, sir.
So two important organs you have to cover: MRSA and pseudomonas. That pseudomonas is very important, like you told. Okay.
So piperacillin can be started, sir. Piperacillin tazobactam or cefepime can be started, or meropenem can be given, sir. If there is associated suspected MRSA, or if there is any skin lesions, or a patient is having indwelling catheters or any PICC lines or anything, vancomycin also should be started, sir.
So if you are suspecting an infection, see prevention of infection is one aspect. Suspicion and starting antibiotic is different. Prevention, you can start ceftazidime, that will be a safer drug. For starting, when you are suspecting a strongly pseudomonas infection, you have to start dual antibiotic. One of the antibiotic should be third generation cephalosporin or piperacillin tazobactam or meropenem. Other one has to be amikacin, tobramycin, like that. Okay. So 2 antibiotics are indicated in pseudomonas infection. Okay.
So, and largely it will depend upon the local antibiotic
resistance pattern.
So if a patient is being treated here for a malignancy or something, and then naturally our antibiogram should be considered for starting the initial antibiotic choice. This is one place where early antibiotics can have a role. Okay, as soon as possible. Some of the guidelines are saying as early as 30 minutes of presentation period in neutropenic sepsis, and the general consensus is within 1 hour.
So procalcitonin is only 3. You only think about pseudomonas infection, or can you think about something else?
Fungal infections can be there.
So here we have to think about fungal, viral, everything. Everything is possible. So we are starting antibiotic empirically for this neutropenic sepsis. At the same time, since we don't have an evidence for bacterial infection, we have to ideally go for antifungal therapy. Okay.
Generally, when you start like antifungals, mostly not as a first line. No? So usual indication will be on day 4. After day 4 of empirical antibiotics, culture you are not getting anything, and the patient is continuing to have fever with clinical deterioration. That will be the time when you go for an empirical antifungal. And what's the choice of empirical antifungal in neutropenic sepsis?
Fluconazole.
Ideally, you have to go for an echinocandin.
Okay.
Fluconazole is only a local antifungal. It will not prevent the systemic infection. If you are suspecting sepsis, that's why Sabarish is asking.
If suspecting fungina, then the choice will be caspofungin, ideally. Or if you are having a lung focus and all, probably you can go for voriconazole and all. But if you are suspecting fungal sepsis, then Caspo is the drug of choice.
And this patient, she is having a hepatitis B also, sir, which was diagnosed recently. We need to send for a hepatitis B core antigen, and this titers, ELISA should be sent.
Viral load should be sent.
But already she is having a neutropenic sepsis, so we have started her on tenofovir, sir, 25 mg OD dose.
In coming to antifungal and hepatitis, among the echinocandins, what is reasonably safer in patients with hemophilia? What are the echinocandins?
Anidulafungins, caspofungins and all.
One more.
Micafungin.
Among them, which is reasonably liver safe?
Anidulafungin, sir.
Tenofovir is NRTA.
Yes, sir.
One of the most important complication of NRTA is lactic acidosis. We should be careful. We have to start. There is no other option. We have to start, but you have to monitor the lactate. Okay. Normally, it will not produce in all patients. Some patients can present with lactic acidosis.
In view of her labs were repeated, sir, that time her total counts were reducing and the absolute neutrophil counts were also reducing. So she was started on colony stimulating factor Grafil, sir.
Can you tell me the indications for Grafil or colony stimulating factor?
Yes, sir.
It is granulocyte colony
stimulating factor, sir. Usually it is given in drug induced or chemo induced.
The only indication for colony stimulating factor is drug induced neutropenia. Other conditions, all it is given as an adjunct, not an indicated therapy or off-label use.
What's the dose?
300 microgram subcutaneous dose can be given.
How long you have to give?
3 days. Depending on the response, we can increase.
Normally, up to the colonic WBC count has to become 10,000. 14 days treatment may be required in drug-induced neutropenia or malignancy drug-induced neutropenia.
It is usually contraindicated in leukemia, sir. Then in patients who are going for chemotherapy, we should avoid this Grafil drug before 2 weeks, and it should be given only after 24 hours of chemotherapy.
Okay.
Is there any drug which can increase platelet counts?
L-thrombopad.
L-thrombopad.
That is also preferred in severe aplastic anemia and chronic ITP.
Basically, L-thrombopathy is designed for hepatitis C induced.
C induced.
But nowadays, it is also indicated in other type of thrombocytopenia.
Then dexamethasone is also started, sir. Dexamethasone.
Why
14.
dexamethasone?
She is a rheumatoid arthritis patient with suspected autoimmune neutropenia, sir. So dexamethasone flare up of
Only relative contraindication here is hepatitis B infection. Should be very careful in this type of patients. Steroid. Since you have started tenofovir for this patient, may be helpful.
Then for this patient, peripheral blood smear was sent, sir. Peripheral blood smear was showing pancytopenia in that. So we were planning on a repeat bone marrow depending on the patient condition, but the bystanders were not willing for the same, sir.
How do you manage rheumatoid arthritis in this patient? This patient is admitted with neutropenic sepsis. You treat that neutropenic sepsis. Sometimes patient will come back to normal without any problem. Other thing, hepatitis B should be treated with tenofovir. Rheumatoid arthritis, what do you do?
We should stop the drugs like methotrexate if at all it is there. Methotrexate, such drugs should be stopped, sir. Hydroxychloroquine can be continued.
Okay.
Steroids.
Steroids, hepatitis B is there. It's a relative contraindication, but some other drugs are there. There are different drugs. Whether we can give rituximab. Rituximab also contraindication is this hepatitis B. That may flare up sometimes. Acutely, if you reduce the immunity of this patient by these drugs, sometimes there may be flare up of the disease, hepatitis B. Okay.
Yes, sir. So this is the we have reached so far, sir. So patient is still in our ICU. We're continuing the same management.
What happened to the respiratory status after
after some time, there was worsening of respiratory symptoms, sir. So we started on Bipap. Then after that, after correction of the hemoglobin and platelet values, and her ABG also improved, sir. Lactic acidosis improved, sir. So we were actually able to wean off Bipap, sir.
Okay. Okay. Thank you.